Okay, welcome back. This will be your video lecture for Chapter 34, Mechanisms of Injury, Trauma Assessment, and Trauma Triage Criteria. Welcome back. Hope everybody's doing good. Everybody's doing well. Let me introduce the chapter. Trauma is injury to the body resulting from external forces. Traumatic injuries affect people of all age groups, and they can occur in any environment at any time. And we have to be prepared to respond to and properly assess and manage trauma patients. So here we have a picture of a typical rollover to vehicle accident. Because injury can occur to anyone at any time, you must be prepared to respond and properly manage trauma. Nice pin job. Looks like they're working on that. Let's talk about kinetics of trauma, the branch of physics, how objects in motion are affected by outside forces, and how energy distributed when objects collide. And that leads us right into Newton's law of inertia. And it basically states that body is going to stay in motion, and the body at rest will remain at rest unless acted on by an outside force. So I think this picture pretty much describes how that works. You have the three collision theory here, where you have the vehicle traveling at 55 miles per hour. It first collides here to the telephone pole. As the body rapidly moves forward, it strikes the steering wheel as the second collision. And then that third collision being the organs moving forward, striking the insides of the body. The law of conservation of energy. Energy can neither be created nor destroyed, and it can change from one form to another. Kinetic energy, right? So this is the function of weight, mass, and velocity or speed. And so if you look at the equation there, force equals mass times acceleration or deacceleration. Because remember, as you're deaccelerating, it's when those organs are striking the inside of the body. We classify trauma in some different ways. We have blunt trauma, which blunt trauma, it can be direct injury or indirect injury. We have penetrating trauma, and this is your stabbings or your bullet wounds. As the object goes through the tissue, energy disperses to surrounding tissues, and that creates that temporary cavity and additional internal injuries. And so we have a picture of that here. As you can see, the bullet coming in the back here, and it's just what it's doing is that separating that tissue out. It expands that area, and you notice the tissue returns after it expands. It returns. And so there's that definition. It normally is on exams, cavitation. And it basically says, as the object continues, energy is dispersed to the surrounding tissue. It creates a temporary cavity or a temporary canyon, and then additional internal injuries. Okay. So low velocity penetrating injuries. These are created by hand-driven objects such as a stick, an ice pick, or a knife. Remember, low velocity and knife injuries. Energy involved is not as significant, but we need to know the length and the width of that object to determine for that potential injury. So the cone of injury provides an idea of how much internal damage may have occurred through movements of the object within the tissue. Let's look at medium velocity now. Handguns and smaller caliber rifles. They produce enough energy to cause injury beyond immediate pathways of projectiles. And then we have high velocity injuries, and these are caused by like your high velocity rifles, massive direct and indirect injuries. So medium and high velocity, we're looking at smaller caliber weapons up to high caliber weapons. Kinetics to determine caliber weapons that created the injury. Important to understand the distance between the weapon when it was fired at the patient. Identify both the entrance and exit wounds. That gives you also have an idea of what underlying body structures have been injured. So back to the scene size up. It's obvious that traumatic or trauma calls probably poses a more serious danger to us. Not always, but probably statistically looking at it, because of the dangers that are there, like down power lines, sharp metal edges when we're cutting people out of cars, gun violence, all of that poses a more risk to us as responders. Identify the number and the location of people injured. And so, you go to a shooting call or a assault call. If there's more than one person injured, let's try to identify the number of patients we're dealing with. What about the location, though? People, after they're shot, they like to wander off. People get ejected out of vehicles. So it's important to try to determine those locations and where do we need to send the additional resources to. Here we have an obvious hazard. We have power lines that are down. We have a small electrical fire or fire created by the power lines over there. So just something that something we have to kind of worry about. So let's talk about the mechanism of injury. So what we're looking at is the forces and the energy that cause the injury. Each MOI has a predictable pattern and the potential for injuries associated with it. It allows you to formulate a list of potential injuries based solely on the MOI. It doesn't always guarantee an injury is present, but it suggests the conditions are right for the injury to occur. It's kind of like a tornado watch. Tornado watches where the conditions are favorable for the formation of a tornado. It's not on the ground yet, but it's a watch. Then if you have a tornado warning, the actual tornado is on the ground causing damage. And so this lets you know the conditions there for the patient are favorable. MVCs, there's the 3 impact thing I was talking about earlier. The vehicle collides with the object. The patient inside the vehicle is forced to deaccelerate by a restraint system or collides with the interior of the vehicle. And then the third would be the actual internal organs collide with one another and the inside of the body. So here we have that vehicle collision here, auto hits tree. So you have that deacceleration when right after this hits the tree, the deacceleration, the restraint system kicks in, and then the actual organs bouncing off one another. So this 3 collision occurs with rapid deacceleration, body collision, body hits the steering wheel, causes broken ribs. Collisions of the internal organs, we could have anything from bruising, lacerations, tearing, can lead to really bad internal bleeding. We just really need to rely on the assessment and the MOI for the indications of that. Objectively, we can look for pale diaphoretic skin or trending vital signs. Excuse me. So this is actual organ strikes, the interior of the chest and abdomen causing additional damage. See, as it's moving forward, it's striking the steering wheel. 5 categories of impact. Well, we have frontal, rear, lateral, rotational, and rollover. Let's look at these. Frontal impact, this is something that we would see on a head-on collision. There's 2 possible paths, and I would try to know these, up and over and down and under. So if you have an up and over or down and under, you can associate that with a frontal impact. Okay. Right here, this is a picture of a frontal impact, obvious frontal impact. If we look at the frontal impact collision here, the occupant continues traveling at the same speed after the initial impact. So if that car is going at 55 miles per hour, then so does the body. The body's traveling at 55 miles per hour. So up and over, so patient collides with the steering wheel, head moves upward toward the windshield. So we need to look at chest, head, neck, abdominal trauma, partial ejections through the windshield. So it's important to consider the predictable injuries of the head, neck, chest, and abdomen associated with a patient up and over pathway. A frontal impact, when we look at the down and under, the patient collides with the bottom of the steering wheel, and in some cases, legs collide with the dashboard. So again, chest, abdominal, lower extremity injuries. Often the lower legs, this is when you get your tib-fib fractures, your ankles and feet are forced into the floorboard and pedals, creating that injury. And we can see a picture of that. Here we have this patient sliding down, striking his legs on the dash. Feet are hitting the pedals, femur, hip, all of those. Something to look for injuries. So frontal impacts, when we're predicting the potential for significant injury, we're looking at more than 18 inches of damage to the car, a starring or shattering of the windshield, a bending of the steering wheel, or damage to the dashboard. Here's that star pattern that you can see. And a lot of times you can see hair that's still that is still there from where the head hit the windshield. We need to examine that chest for internal bleeding, compression, sharing, or injuries of the heart and lungs. The air pressure itself can cause a rupture of the lung tissue, causing a pneumothorax. The abdomen, again, compression and sharing injuries. Liver and spleen can be injured, leading to massive internal bleeding, which could lead to death. If we're looking at the head, we're looking for anywhere from mild lacerations to a massive skull fracture, closed head injuries, open head injuries, neck injuries. When we examine rear impacts from MVCs, the vehicle is obviously struck from behind. The driving vehicle moves forward. Acceleration of the vehicle causes acceleration injuries. Then we have whiplash. Whiplash is defined as a hyperextension that can lead to serious injury or soft tissue, spine, or even spinal cord injuries. Here we have a picture of a rear impact. So here again, we have the patient who's driven forward into the steering wheel, but that rapid deacceleration slings the patient backwards, causing that whiplash injury. Lateral impact. So these are also known as T-bone collisions. We need to determine if intrusion into the passenger compartment of the vehicle occurred at what location. So fractured extremities on the side of impact, lateral chest trauma, hip fractures, and head and neck. Here's a picture of a lateral impact with definitely some good intrusion here to that vehicle. So in the lateral impact, you see this patient being struck and moved over to the other side. A rotational impact causes the vehicle to rotate or spin. That can occur from either the front or the rear fender of the locations. These are the ones that hydroplane on the interstate and have that 360 turn where they hit the wall and then hit another car. Those twisting forces can lead to significant injuries, neck and internal organs. Here we can see like the rotational impact occurred here from the lateral impact. It caused the patient's vehicle to rotate or spin. Rollover MVCs. Patients are subject to forces of every kind, and these can also lead to significant injury. The unrestrained individual inside the vehicle may be ejected from the vehicle. Patients who have been ejected usually sustain serious injury or even death. Here's a picture of a rollover, one vehicle on its top. Rollover MVC subjects the patient to forces of every kind. And you can see this patient right here went for a ride, thrown all over the vehicle. So pedestrian versus vehicle collisions. A lot here to process: the speed of the vehicle, the part of the body that was struck, how far did the patient was thrown from the vehicle, the impact of the vehicle, but also we have to consider the impact of the ground, and what type of surface did the patient land on. All of these are important. Adults tend to turn away from the approaching vehicle, whereas children tend to turn and face directly towards it. When a person is about to be struck, they tend to turn his back to the coming impact, absorbing either on the lateral or posterior side of the body. As the vehicle impacts the person, it lifts them off their feet with a forward movement of the vehicle and causes them to impact the windshield of the vehicle. So the patient sometimes is picked up and thrown upwards. If that speed is substantial, person will travel completely over the vehicle. If the driver deaccelerates, person can roll off the hood of the car and strike the ground and causing additional injury. Motorcycle crashes. So yeah, the driver of that motorcycle is very exposed. There's more risk for injury than the driver of the automobile. If they're not wearing a helmet, then there's obviously a greater chance of sustaining a head injury. Head-on motorcycle collision where the rider can be thrown into and over the handlebars and continues until they come to rest after striking the ground. So you have a picture here. This guy was hit, probably come out of his shoes there. Not good. That's serious damage there to that bike. Lateral impacts of motorcycle collision. The rider is struck by a vehicle and they sustain injury to the leg or on side impact. After impact, the rider loses control and crashes. The person riding the motorcycle is ejected off that motorcycle. And even when the helmet isn't worn, it goes without saying, there's a greater chance of a significant head injury. If we look at falls, we're going to obviously understand the height of the fall. We want to look for the body part that hit the surface first. What kind of surface did we fall onto? There's a direct injury and an indirect injury path. The direct injury, the patient's body contacts the ground. But the indirect injury comes from energy that continues to be absorbed by the body, and this causes additional injuries. And we can look here at a picture that kind of explains that. So we see where the victim lands on his feet often fractures the lumbar spine because that energy goes all the way up. And the force transmitted to the vertebrae causes those compression fractures. Let's look at blast injuries. Usually a result from an explosion, natural gas, fireworks, IEDs. Ensure the scene's safe. We're going to look at the 5 phases of injury. We have the blast injury, the secondary blast injury, the tertiary blast injury, the quaternary blast injury, and the quinary blast injury. So let's talk about those. The primary blast injury is a pressure wave from the explosion that directly related to the force of the explosion. The secondary blast injury can be defined as debris thrown from the explosion as a result of a pressure wave. So you have the primary blast injury. The secondary blast injury could be, like a screwdriver or hammer or whatever that's thrown from the explosion that could actually strike the patient. The tertiary blast injury, this is that pressure wave and debris hit patient thrown away from the explosion. The quaternary blast injury is actual environmental conditions following the explosion. So did it start a fire? Did, what have you? And then the quaternary blast injury is the hyperinflammatory state caused by the exposure to contaminants from the blast. So this could be, whatever the chemicals that could have been used inside the bomb or the explosion, and that exposure to the patient because of that. So significant MOI here, we're looking for to be significant. Is it an ejection, death in the same vehicle, a vehicle telemetry consistent with high risk, pedestrians or bicycles thrown, run over, or with significant impact, and falls greater than 10 feet for all ages. Riders that are separated from their transport vehicle, these are a motorcycle, ATV, or even a horseback riding. Penetrating trauma to the head, neck, torso, or proximal extremities, and an amputation to a proximal to a wrist or ankle. So if you see these that we just covered, you need to maintain a high index of suspicion and transport to a level 1 trauma center. Again, we're going to cover a few more that are high index of suspicion of injuries. Ejection from a vehicle, which we just talked about. I think we talked about all of these. We did. So a non-significant MOI, less severe injuries that require our care, your role, assess the patient, treat and package, and again, transport to the appropriate facility. Let's look at the assessment of the trauma patient. So obvious things are, life threats, airway, breathing, circulation, We want to use a systemic approach, just like we do on a medical call. Except these patients, the difference between a medical call versus a trauma call, in the medical call, we're going to do more of a symptom approach to that, meaning we're not going to do a head to toe on a medical call, right? We know this by now from practicing in the field. We're not going to do a pelvis rock on someone with difficulty in breathing. Just not going to happen, right? But most of your trauma patients are going to need that head to toe exam. We also have to be careful not to be distracted by gruesome injuries like an evisceration. We can't focus on that when we maybe have somebody who has a chest injury, a penetrating chest injury, something like that. We have to be aware of. Most of these trauma calls require manual stabilization of the head and neck. We are going to examine for neurological deficits, altered mental status, and provide that inline stabilization. Here we have an example of that. We're really going to check that airway. We'll make sure that it's clear. We're going to listen for those sounds of gurgling, snoring, stridor that lets us know that there's airway occlusion. We're going to apply oxygen to maintain an SpO2 of 95% or higher. If we notice signs of inadequate perfusion, hypoperfusion, shock, whatever you want to call it, we're going to immediately provide O2 at that point. We're going to make sure we listen for lung sounds to see if we can identify pneumothorax. The primary assessment for circulation, obviously pulse rate, and we're going to feel for that radial pulse. We know if the radial pulse is absent, then our blood pressure is less than 90. We want to really look at that skin condition. Are they pale? Are they cool? Are they diaphoretic? Are they mottled? And something called that blood sweep. That blood sweep comes with your rapid head-to-toe assessment, where you want to go from head to toe, and at the end, you want to look at your gloves to see if you see any blood on them. And that's something that I've noticed in the last books we've had. It's called a blood sweep, and I think I know where it came from. It came from the Air Force on their pararescue type teams there, that they teach this blood sweep. Again, pulse rate, rhythm, and quality, and location of that. If it's a radial pulse, if it's a carotid pulse. If we see bleeding, we need to control it. The disability, and disability means the patient's level of responsiveness. Always use the AVPU mnemonic. They're either alert, they're verbal, they're pain, or they're unconscious. And we're going to determine that GCS score. Here we have an example of Glasgow Coma Scale. We should all know this by now. I don't think I really need to cover this. We know that, somebody dead can have a score of 3. We hopefully have a 15, but we're just going to put the score together. We need to expose those critical trauma patients so that we can do an appropriate exam. It's just essential, if you have somebody meeting those MOIs, that we expose them and check them for injuries. We're going to keep them warm. We're going to protect their modesty, but you cannot treat what you can't see. And, how many times we get a call where somebody's been shot and we're treating that single gunshot wound, and we get to Grady and then they expose the patient, and they find that second or third gunshot wound. That's on us. It's super important. If you have that gunshot wound or stabbing or anything else that meets that MOI list, that we expose those patients. I mean, you don't have to believe me. You can get burned later, but you will get burned on those if you don't get those folks exposed. The secondary assessment, so this would come after the rapid trauma exam. This is where, well, the rapid trauma exam is part of that secondary assessment. It's just really quick. And we're going to, at this point in time, get an actual blood pressure as part of the secondary assessment, collect the medical history. You can do a focused head-to-toe exam, depending on the MOI and the complaints and the overall condition. So there's nothing wrong with doing a really quick head-to-toe, sweeping them for blood, getting a set of vital signs, getting your IVs going, and then going back really quick, or not really quick, but going back for a more thorough secondary assessment while you're en route to the hospital. There's nothing wrong with that at all. So the rapid trauma exam I just mentioned, it's a really quick visualization and palpation of vital areas to identify life-threatening injuries. And it head, neck, chest, abdomen, pelvis, posterior, and the extremities. So that's, here we have a rapid trauma exam going on. This provider is holding C-spine control while his partner does a really quick sweep of that. So baseline vital signs, we're looking for trends, right? And those trends being, remember, systolic blood pressure represents the health of the overall left ventricle. At the end of the day, I mean, I know what cardiac output equals heart rate times stroke volume, and we can make this difficult or we can make this simple. And systolic blood pressure represents the overall health of that left ventricle. The diastolic blood pressure represents vessel size and diameter. As epinephrine and norepi is released by the body, that diastolic, those vessels constrict. Their diameter becomes less. They constrict to try to bring blood to the core of the body. We can see this in trending vital signs. We can start off with a blood pressure of 128/84. And that's a normal blood pressure all day long. And our next set of vitals might be 122/90. Even though that's a normal vital sign, our diastolic is creeping up and our systolic is creeping down. The third blood pressure might be 100/86. Again, we have a systolic, that left ventricle is being overworked, trying to keep up with demand, and that those vessels are just constricting, trying to bring blood to the core. Those are very subtle signs that our patient it's not compensating anymore, but now they're in decompensated shock. Super important. If we can get a history on this patient, let's go ahead and get it. I don't need their childhood problems. I need to know the majors: cardiac history, high blood pressure, diabetes. Are you allergic to any medicines that you know of? Because when we get these patients into the trauma center, we're going to want to hang antibiotics, right? And if the patient's allergic to penicillin, that's a big deal. So critical trauma patient, someone with a GCS of 14 or less than 14. So if your patient's confused, they're 14. If you have a systolic blood pressure of less than 90, or the MAP below 60 to 65, then that's a critical trauma patient. A respiratory less than 12 or greater than 29. So their respiratory rate is going to increase. Why? Because they're acidotic. They're acidotic. They're trying to blow off more CO. And therefore, their blood pressure, their respiratory rate is going up. But the goal of trauma is to treat and package and begin transport. We don't carry blood yet. We're way behind the times. We should have been carrying blood 30 years ago. I don't want to get on that. I don't want to be negative this morning. I want to try to stay positive. But it makes me extremely angry to think about where we should be at this point in time in EMS and pre-hospital care. So our goal is to get that patient packaged, get them off that scene, and get them to the hospital. That means you do not start IVs while you're on the scene unless you're waiting on AMR. Your goal is to start that IV while you're en route to the hospital. That normal saline or lactated ringers does not carry red blood cells. It will not oxygenate the blood. It will not help blood loss. Matter of fact, some studies suggest that it actually is worse by fluid bolus in a trauma patient because we're washing out the platelets. And so hopefully one day they'll take what we do seriously and we'll get the proper tools that we need to do our job. Focused trauma exam is isolated injury without significant MOI. And so this could be like you have a patient who was walking in the front yard, the grass was high, they stepped in one of those water meters, and they have a isolated femur fracture. So, yeah, we got time to put a hair traction splint on that patient. We're still going to do a head to toe because that femur fracture is so painful that it might distract us from other injuries that could have occurred in that. But that would be more of where you would see a focused trauma assessment. This is just going to cover the head to toe assessment. I think everybody is familiar by this point in your career of how to do a head to toe assessment. So reassessment for your patients who are meeting those MOIs, we should do their blood pressure, vitals, reassess every 5 minutes. Also, try to train yourself. I realize you're not going to be timing this. I get that. Right. But try to force yourself. It'll help you in your career so much if you'll remind yourself when you're going to reassess to try to get the general impression of the patient. Again, means look at them. Just look at them for 15, 20 seconds. Then ask them how they're doing. I just want to hear something from them that lets me know that they're still with it, that they're still alert. That goes a long ways. Because when you get to the hospital, you can say, hey, look, about 8 minutes ago, we noticed that the LOC seems to be deteriorating. It's just something to add in your verbal report to the trauma team that lets them know how serious this patient could be. Non-critical, these are your isolated femur fractures or your isolated trauma. Every 15 minutes is fine. We need to transport to the appropriate destination. To a hospital that's capable of handling this call. It is so disappointing working at Rockdale when I see so many trauma patients that we have to fly out of the ER that should have been taken to a level 1 trauma center. It's super important that we get them to their appropriate facility. When it comes to when we're considering air transport, Some things to consider: the ETA of the aircraft. And this is why we don't fly that many here at DeKalb. I have flown a couple from 17's immediate when they were working on the interstate going into the city, because it made sense, right? I knew the ETA they're usually there pretty quick. But you also have to consider, even though they get there quick, there's a handoff report that has to happen. The flight crew is going to they're going to do a head to toe. They're going to assess a set of vitals. They're going to consider whether this patient needs to be intubated. Do they need to, what's this patient going to be like en route to the hospital? Do we need to go ahead and paralyze them and intubate them? They're going to consider all of that. Even the best flight crew is going to be there 10 minutes. So you got a 10-minute ETA or a 15-minute ETA. You've got a 10-minute to 15-minute on-scene time by the helicopter before they get off the ground. And so you can add that up. That's 30 minutes. Where could we be in 30 minutes? That's something to think about. Also consider the weather conditions. And do you have an appropriate LZ where this helicopter can land? All right, that's it for this chapter. I'll be posting it pretty soon, and look forward to seeing you in class.